here in this session, we bring together these three amazing experts, yourselves as stakeholders, and we're going to explore this impact of this critical issue on heart health. So we're going to look at some of the evidence, including how pollutants contribute to the development and exacerbation of cardiovascular conditions, discuss the scale of the problem, maybe looking at some epidemiological data and some case studies. And then we'll also look at scalable and actionable solutions to mitigate these cardiovascular risks, perhaps touching on policy, on advancements in health, in air quality monitoring, as well as individual preventative measures. So it's really exciting for me to present to you our esteemed panel. I'm just going to turn my pages here. Possible to do this. So our esteemed panel are really the leaders in these areas. It's a great pleasure for me to introduce to my left here, Professor Prabhakaran, better known as Prof. Prabhakar. He's a cardiologist and epidemiologist, an internationally renowned researcher who is a distinguished professor at the Public Health Foundation of India, a professor of epidemiology at the London School of Hygiene and Tropical Medicine, and the executive director for the Center of Chronic Disease Control in New Delhi. He leads the NIHR Center for Global Health, and he focuses his research as well as his science on chronic disease prevention in India and as well as in other low and middle income country settings. And his research really spans the entire profile from mechanistic research all the way to developing solutions, as well as translational research and human resource development. Prabhakar is also on the World Health Federation for many years on the board, and was also part of the steering committee for this Congress. And we really thank him for being part of the panel today. Our local host is Prof. Haydong Khan. He's a distinguished environmental health scientist and a professor at Fudan University. And his research focuses primarily on the health impacts of air pollution. Notably, his group concluded a key cohort study here in China, providing some key evidence on the International Agency for Research on Cancer to classify outdoor air pollution and particulate matter as carcinogenic. He's also a regional director and editor for the journal Environmental Health Perspectives and an editorial board member of the international journals Epidemiology and Atmospheric Environment. So welcome and thank you very much for being with us. And then Dr. Anne Ehrherz is the head of the Novartis Foundation. A real pleasure to have you here today. This is an organization that is dedicated to improving health in low-income populations through data, digital technology, and artificial intelligence. All three, of course, absolutely critical for improving health. She's deeply committed to addressing health inequities and pioneering innovative solutions to advance global health and care. She has been on multiple boards related to digital and AI in health. And before leading the Novartis Foundation, she was at Novartis Pharma as well as the International Committee of Red Cross. So thank you so much for being with us. So what we're going to suggest is I'm going to ask our three esteemed panelists just to give us a little introduction, give us some of their background and their particular thoughts around this topic before we dive into a few questions. So I'm going to ask Prabhakar to get us going, speaking maybe a little bit more about some of the evidence, some of the trends. But over to you, Prabhakar. Thank you.
Thank you, Dr. Zulke, and it's always a pleasure to be at the Heart Cafe. Now, air pollution has been in the news for the last 10 years or so. In fact, it had been identified much earlier, but over the last 2 years, the knowledge, the science, and the evidence has accumulated considerably in terms of its relationship to cardiovascular disease. But unfortunately, if you ask even physicians, well-known physicians, as to what does air pollution produce in terms of health, they would talk about respiratory diseases, childhood pneumonia, but actually ignore air pollution completely. Air pollution causes almost 7 million deaths in the world, of which nearly 50% to a third, to two-thirds is because of stroke and coronary artery disease. And that's the magnitude of the problem, but less understood, less evaluated because of because of various reasons. Now, how do we measure air pollution? Air pollution conventionally has been measured using particulate matter. Particulate matter is a composition of several toxic and noxious substances, both gaseous and heavy metal. But it can be classified into large particles like PM10 and very small particles like PM2.5. The confusion with regard to respiratory diseases is because of PM10. It doesn't cross the alveolar blood barrier, whereas PM2.5 crosses the alveolar blood barrier, and it can directly damage the endothelial cells, causes stiffening of the arteries, directly impact the heart, can get deposited in the fat cell, increase the inflammatory potential, act as an endocrine disruptor, and cause myriad diseases. Particularly in terms of cardiovascular disease, the strongest evidence is linked to stroke, followed by coronary artery disease, and several of the risk factors that includes hypertension, diabetes, and lipids. In fact, a study by Jumbo Gay, who's the chief patron and organizer of this conference, his team has studied air pollution in more than, I think, 380 cities and involving hundreds of thousands of patients, and shown that even within 1 hour of high exposure to PM2.5, there's an increased risk of myocardial infarction. So it all depends on the individual vulnerability, the amount of exposure, the type of exposure. For example, in the Chinese population, the type of exposure has been attributed to nitrogen dioxide, whereas world over it is PM2.5. But also there is a problem in terms of the estimation of PM2.5 and other elements, because most people use satellite-based data, which has got its limitations. Its accuracy ranges from 70 to 85% or so. We in India have developed a machine learning AI-based model, which uses four streams of data: satellite, monitoring station data, emission inventories from polluting industries. But we also adjust for land use, the road pattern, the presence of transport networks such as metros, then adjust for meteorological variables, because the air pollution variables are not static. They can change based on the temperature, based on wind speed, based on humidity, and several other factors. Using such a large adjustments and using various machine learning models, and we use four machine learning models and create an ensemble model, we have reached an accuracy close to 90%. And therefore, we require robust estimation. Second is the estimation of the health outcomes. Again, we require large longitudinal studies. But given the fact that many countries are progressing towards establishing longitudinal studies, we have a lot more evidence now. We have a lot more confidence in telling that air pollution is bad. So I'll stop here and come back again.
Yeah, thank you very much, Prabhakar. I mean, the fascinating data that you have and those models are really very impressive. I'm going to turn over to Professor Hanya, just to give us a little bit of a sense from yourself and your area of work, what you feel.
Actually, very nice. First, very nice to be here. And I work on air pollution and health in China. And I think China actually is among the one of the factories with the worst air quality in the world. And I think the worst time period was like 12 years ago. And during that time, we see a lot of very smoky days. And after 10 years of government efforts, I believe China's air quality has improved a lot. I mean, compared with 10 years ago, the PM2.5 level in Beijing, in Shanghai, was like around like 50 percentage of 10 years ago. So air quality have improved a lot during the past 10 years. For example, in this city, Shanghai, the annual average PM2.5 concentration in Shanghai in the last year was around 25 microgram per cubic meter. I mean, compared with 10 years ago, air quality in China have improved a lot. But compared with the World Health Organization global air quality guideline, I mean, for annual average, it is 5 microgram per cubic meter. Air quality in China, we still have a long way to go. But that's the exposure level in China. And if we talk about health, I think China, air pollution is now still the top risk factor for mortality in China. And according to the Global Burden of Disease study, every year in China, around 2 million people die due to air pollution, accounting for like about 20% of total mortality in our country. So it's a big problem. It's a big problem for environment. It's a big problem for health, and also big problem for health economic disease burden. So I think we still have a long way to go. And the final thing I would like to mention is it's very hard. I mean, I'm a public health person. It's very hard to convince the cardiologist to believe air pollution is a risk factor for cardiovascular system. We have a long way to go to make the physician believe these things. And I understand the physician is the most powerful person to 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 ask the patients to change their lifestyles. So we think so we need to work more to 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 work with cardiologists to to improve air quality related cardiovascular problem.
Thank you so much. Really interesting that to hear about that improvement, although still not to the standards. We're going to delve into that a little bit later because it'd be interesting to hear what strategies were
Yes.
employed to achieve that. And then we welcome you here as a public health specialist to a cardiovascular meeting because you actually are starting that dialogue to allow cardiologists to get on our side here. So thank you for that. I'm going to hand over to Dr. Anne Etz now, just to give her perspective before we do a little bit of Q&A. So over to you.
Yes. For us at the Novartis Foundation, we focus on cardiovascular population health, and we have implemented.
I suggest maybe use this mic.
Implemented major models for cardiovascular population health in urban settings. And while doing that, one of the first cities we chose to do that a lot of years ago was Ulaanbaatar, the capital city of Mongolia, not so far from here, because it has the highest cardiovascular mortality on earth. And guess what? It is the most polluted city in the world during the winter months, at least. During 9 months when it's very cold in Ulaanbaatar, there's absolutely no wind, and the smog hangs over the city. If you do walk on the stairs, you are out of breath. It's really incredible. So that's probably very much linked. However, this model of cardiovascular population health, cardio for cities, in the meantime has evolved, and we also rolled it out in Brazil, Sao Paulo, city of 16 million, in Senegal, Dakar, in Ho Chi Minh City in Vietnam, and now we are bringing it to 30 other cities in the world, together with the World Heart Federation, and we already started in Melbourne, European cities, and hope to go to many other places. However, at the foundation, we decided to examine what truly drives cardiovascular outcomes, because we know that only 20% of our outcomes is driven by the health care we access. And I fully agree that it's from the public health side that the solutions will have to come, at least in the field of air pollution. So what we do is work with very data-rich cities at the moment. We work with New York City, where you have all the data available on anything you can imagine, the tap water in your kitchen, or the air quality, or the transport situation, whatever. You can have all data available. Singapore, which has a very nice unified data system as well in one place, one platform, and Helsinki, the best data system in the world, if we can believe that lifelong cohorts data will give us an answer to all of these problems. So what we do is bringing all the data from the underlying determinants of health, and that includes air quality, but it also includes your food quality, your access to physical activity, but also your access to digital solutions, internet, education, all of those factors into one single computer in partnership with Microsoft AI for Health. And we let that computer tell us what is the main factors that drive cardiovascular outcome in the city. And we see that air pollution comes out as an important factor, but it's not the highest one, as we now see in the burden of disease study. It is particularly important to PM2.5 in New York City, for example, only for hypertension. It is not important for diabetes. Only 4 factors drive 70% of the diabetes and other cardiovascular risk factors. And that is your education level, your access to internet, your access to healthy food or food in general. And lastly, the fact that you live alone, so social connections. So these 4 factors in all of the US, because we used all of the US data to predict it in New York, drive your outcomes. Air pollution specifically drives hypertension in this study. So that's our findings until now.
Gosh, that's really so interesting. Thank you very much for those insights. And I have to say, it sounds an incredible program, but also that it's different in different places. So really interesting. Thank you very much. I just want to pick up on a comment from Professor Ken earlier, and linked with what we've just heard about the difference in different areas. So I wonder if you could comment and elucidate a little bit more about what happened in Beijing and what were the policies that were enacted, and then how do you find it different in the different regions of China? Obviously very diverse, very rural, urban, etc. What is the difference that you note?
Okay, thank you for asking the question about China. Actually, in different part of China, the air quality is different. For example, for PM2.5, in North China, PM2.5 level is much higher, compared with South China. But for ozone pollution, the pattern is different. Actually, the highest region is in South China, like Guangzhou, Hong Kong area. So from a spatial distribution, the pattern of different pollutants are totally different. I think for Beijing, the United Nations has listed Beijing as the most air quality improvement city in the world. And I believe 10 years ago, air quality PM2.5 level in Beijing is 2 times higher compared with Shanghai here. But nowadays, it's almost the same. So I believe, for different part of China, we can take effective major policies to improve the local air quality. So that's it.
No, that's very impressive, and Beijing and the city can certainly be, and the country can be congratulated on that. That's a unique accolade to have the most improved city in terms of air pollution. Can you perhaps give us 1 or 2 interventions that were done to be able to achieve that?
Actually, I think several policies are related with the air quality change. For example, the energy transition. 10 years ago, the Chinese people used coal as a major source of energy, but nowadays natural gas is a major source for cooking, for heating. And in China, in North China, the temperature is much lower. So in the winter, people use coal for heating. But nowadays, people use natural gas for heating. It's a big transition. And another apparent change is the transportation. 10 years ago, on the street, you say most cars use oil. But nowadays, if you go out in Shanghai, you can see more than half of the cars use electricity as the driving energy source. So I think several policies are related with the air quality change in China.
Fascinating. I mean, it also speaks to the fact that it's not just a change, but it's a policy change that actually makes sure that we have the impact that we want. I'm going to go back to the issue of cardiovascular health, and this is for you, Prabhakar. I mean, one of the things that you mentioned was how the air pollution actually affects heart disease. And you gave us some of the numbers. I mean, what is the mechanistic pathway for that? And how can we then interrupt that mechanistic pathway?
Right. As I mentioned earlier, the mechanistic pathways are threefold. One, the PM2.5 crosses the alveolar blood barrier, enters the blood circulation, and actually damages the endothelial cells, but also causes stiffening of the arteries. In fact, I would agree with Dr. Arts that the strongest relationship is with hypertension. In fact, in our own study, we found that every 25 microgram per cubic meter increase in PM 2.5 increases blood pressure by 3 to 5 millimeters. And if you actually translate it to a population level data, and if you bring down the PM 2.5 level to the national ambient air quality standards, which is much more liberal than the WHO standards and stands at 40. If you get it down to less than 40, your prevalent hypertension can come down by 15%. That's the power of intervention at an environmental level. Second, it's an endocrine disruptor, and it also causes inflammation. And as we know that South Asians have very high propensity to diabetes, and our own studies have shown that there's a 22% increased risk for developing diabetes as we go along with every 10 microgram increase in PM 2.5. And it increases every 10 microgram per cubic meter of PM 2.5 increases the HbA1c by around 0.02 units. Because we are talking in terms of not 10 microgram in Delhi, the annual average is 100. So you multiply it by 10 times. So you're talking about very high mean levels of hemoglobin A1c. In terms of lipids, again, there are changes where there's an increase in LDL cholesterol, increase in triglycerides, and no change virtually in HDL cholesterol. That's related to the physical activity. People with higher levels of physical activity are likely to have higher level of HDL, but because of the antagonistic effect of PM 2.5, it comes down. Then people with disease, people with heart failure can rapidly deteriorate. People with stroke can deteriorate. And then we recently published a paper on, or publishing a paper on interaction between temperature and PM 2.5. In fact, it's a very strong positive interaction. And given the fact that we saw huge amounts of deaths due to heat wave, it becomes worse when PM 2.5 levels are high. So we should not look at air pollution in isolation. It is a composite of everything. It's a composite of temperature change. It's a composite of other pollutants. And it's also a factor in climate change. I mean, it's one of the interactive factors for climate change. It interacts with food systems. It has been shown that some of the nutrients in water depleted areas, the nutrients are decreased in fruits and vegetables. We ask our patients to take fruits and vegetables. So there is multifarious interactions, and we need to pay attention on that. But clearly, I would agree that amongst the risk factors, hypertension is the highest. Amongst the disease, the relationship with the stroke is highest. So I think hypertension and stroke are interrelated. The other thing we should not forget is the collinearity. Dr. Ertz mentioned 4 factors, but there's a huge collinearity in the first 3 factors.
Mm. Yeah, no, it's fascinating. I mean, I think what you've talked about there in particular is these multiple levels of factors, and so that interventions must also be multidimensional.
Yes.
In your center, the various interventions that you're undertaking, how are you doing this multidimensional sort of transdisciplinary interventions?
Let me start off with the medical field itself. As the adage goes, physician, heal thyself. So if you look at the health system itself contributes in the world to 5% of the greenhouse gases. If you put all the health systems together as a country, they would be almost the size of an average European country. So it's very big. And there are very simple things like sustainable procurement, waste management, efficient use of gaseous in the anesthetic milieu. All of those can help. Second is we need to improve the capacity of cardiologists, physicians to talk to patients. It's very important that our patients who are really sick should not go out on a day where the PM 2.5 is 300 or 400, or they use a N95 mask or a N99 mask. Second is air purifiers. We are working on developing low-cost air purifier, and we are doing a trial of the low-cost air purifier in heart failure. So research is needed. Capacity building and behavior change communication of the general population is needed. So if I have to summarize, and then of course the policy options, clean fuel, phasing out the solid and fossil fuels, speciation, what is the cause? In every location, the species of PM 2.5 is different. It may be because of transport, it may be anthropogenic, it may be agricultural residue burning. There may be multiple factors. We need to identify that. We need good exposure assessment models. So there are multiple things that we do. If I have to summarize what is really needed, I think is 3 E's. You need an empowered community. You need an energetic profession, because the profession can actually influence, they can become lobbyists for change. They can influence a policymaker, and you require an enlightened polity. So all the three together can actually make a big change.
A beautiful summary of those three factors. And I think that really gives us also interventions in each one of those three that can encompass those whole areas. If I can turn to you, Dr. Eds, I mean, one of the important things is in your AI Healthy Cities intervention has been the integration of AI and focusing on urban health. And I wonder if you could maybe address what the role of AI and how you integrate that into the role of your health systems, your cardiovascular technologists, and of course your environmentalists as well.
Yes, thank you for that question. In fact, we are truly convinced that we need to be able to quantify which combination of factors is really the most beneficial or the worst for your cardiovascular health. As you say, it's so multifactorial. I cannot agree more, but we really need to pinpoint what should we be acting on. Currently, policymakers, with all due respect and congratulations with the fantastic achievements, but we are making a lot of opinion-based policies. We are not following the data. We need to shift towards evidence-based policymaking. And to do that, you need to use the massive amount of data we have currently and advanced analytics such as AI to understand that. We don't do that for the research. AI for Healthy Cities is really a program that is meant to then feed back into our Cardio4 cities, the cardiovascular population health models in all of these cities we roll out as interventions. So we want to equip policymakers and health system managers, but also health providers, obviously, with the tools that would enable them to apply precision population health. This is what we need, not any more opinion-based population health, but precision population health. If it's pollution that needs to be acted upon first, then that will be the result coming out of the simulator. So all of our data insights, we are translating that into simulators for decision makers so that they can see, if I invest my $1 million in this intervention, this is going to be my health impact. And if I don't invest it, this will be my health impact. And on the other hand, that will then build roadmaps that use precision population health to decide what are the interventions necessary. And they can go to from working with agricultural farmers across in Africa. We did that to make sure that they deliver healthier food, or working with the transport sector to have more electrical vehicles available or more electrical charging stations available, for example. That definitely is part of it. But also, it doesn't help if you only address one factor. We know lack of access to internet is the second most important factor driving your cardiovascular health. Does that mean that giving you access to a computer with internet will improve your health? No, not at all. It is linked to a lot of mediators in the middle, and that has to be delivered by AI as well. So we do an AI-enabled systematic literature review to pinpoint what are the mediators, because you cannot have data on that. There is not enough individual behavioral data in the world, except the wearables, but no one gets access to that data. So you need to be able to get it from all of the published literature, and only AI can get that out of there. So that is the second part of our AI for Healthy Cities, in fact, so that we make sure we understand why is it that if you don't have internet, you have such a bad outcome. This is mediated by a lot of other factors.
Thank you so much for that. I think one of the things that we often talk about certainly in the cardiovascular community, but in most of the health communities, is the threat of AI. And here you're actually talking about the opportunity and what AI can add to the picture, which is so crucial. So really, thank you very much for that. I'm going to pass on to Professor Can now about impact. So we heard about this also from Dr. Ertz. And it's interesting having had that change over the last 10 years. Have you seen impact on health outcomes? And then potentially, how have you used that impact on health outcomes to improve the advocacy in this area?
Yeah, with the air quality improvement in China, we already observe several change of health outcome related with the air quality changes. The first is the reduced mortality. I think several published studies have already showing that the reduced mortality in China were huge due to air quality change, like that hundreds of thousands of days avoided every year in China. That's the first thing. The second thing is about reduced hospital admission. And several studies in China, like child study, CLHS study, already published literature, have shown that the reduced hospital admission due to air quality improvement. The third thing is about reduced preterm birth. Preterm birth is a very important risk factor for, I think, for the whole disease burden among population, and several published study already showing reduced uh, reduced preterm birth due to air quality changes. So that's the thing we already observe in China. And the other thing importantly is public awareness. And I think due to the air quality changes, we see more and more blue days in the cities, and people pay more attention. People have more public awareness about health hazards of air pollution. So that's the another important issues.
I think those are three absolutely vital issues when we're talking about empowering a generation. So really thank you for that. I'm glad you've got the mic there, Dr. Eds. I wanted to ask about community engagement. So I love the term precision population science and data-driven interventions, but often when people talk that way, they do neglect the community. And I wondered about how this links with community engagement.
Yeah, this is a very important factor indeed. We may not forget communities. They have to be around the table when we design population health roadmaps. In any case, they are front and center of these population roadmaps, in fact. And we see already in New York and also in Singapore with our data-driven analysis and the results that come out of there, we may miss out to the invisible populations, the most underserved populations. So what we do is complete our AI for Healthy Cities, not only with a literature review, as I said, but also with a qualitative vulnerability assessment where we have a huge anthropology group talking to the different communities and asking them, what do you think will improve your health most? And then that is the most useful information. But they also pinpoint areas that we have forgotten or types of people we may miss in our quantitative analytics. So we have to combine it with community engagement. That is absolutely key, and they are at the seat, in the center seat, together with the authorities of the city, to design these roadmaps. This is driven by the local mayor and their offices and the local communities. It's not driven by us. We just inform them with the best possible data. But to add to Professor Haidong's point, I wanted to raise a flag that we should not forget in many places around the world. It is not necessarily about the city's air pollution, but the indoor pollution that is causing all these huge numbers of premature deaths that can be avoided. So one of the main interventions there is community-based. You have to start working and convincing the people who are cooking for their families, whether that's the moms or the dads, that they use clean energy. Clean cook stoves is one of the things that made a lot of change in Africa, for example. But it's something that people never think of, this indoor pollution. So we shouldn't forget that. In fact, it's the main factor for pollution-related cardiovascular health, I believe. So we should always think of that as well. Maybe not as much anymore here, but in many other places, yes.
No, absolutely. I think I remember hearing a fact that was one of the factors that actually is common to the poorest people in the world as those that are in indoor cooking over fossil fuels. So yes, thank you for that. And thank you for those insights in terms of community engagement, which I think are critical. You raised the point, Prabhakar, that the cardiovascular, the health systems or the health environments are actually part of the contributing factors. What do we need to do with the cardiovascular community, the cardiology community that sometimes think in silos? What kind of interventions besides this kind of moments would you suggest?
I mean, I kind of summarized it a little earlier, but I think to emphasize the point, the cardiologist should be educated on the ills of air pollution, particularly in terms of cardiovascular system, stroke, coronary artery disease, and the various risk factors. That's number one. Number two is that for cardiologists, it's important to talk to the patients. Number three, talk to them about the ills of air pollution. How can they combat that? Number three, I think cardiologists are the most powerful citizens in any country, and they have the influence, they have the reach, and they have the ears of the politicians, and they should use that to their advantage and think of how to change policies. I just wanted to add a few things about community engagement. We think that behavior change communication, we give information to patients or information to people, and that's adequate. That's not adequate. It improves knowledge, but doesn't change practice. When we think of behavior change communication, we think of three things. The first factor is I know. So we give them the knowledge so that they say, I know. But we need to empower them, and we need to make advocates of change so that they can say, I can and I want. And I think we require all the three. Then there are a lot of advances in community engagement now, including photo voice, people's voice survey, discrete choice experiments. And we should use all of that to co-create and co-design the interventions because there will be local ownership. It will be better implemented. So, and cardiologists can play a major role in that. They should become leaders in the community. Like, for example, there's a walk with the doctor program I think in Columbus, Ohio. It's quite a popular program. Every weekend, the cardiologist walks with the patient to improve physical activity. So we could design some programs in terms of air pollution. The third is the equity dimension, which should not be lost. Particularly women who actually do all the cooking in most part of the world are exposed to the highest levels of indoor air pollution. Not necessarily because, I mean, if you give them the clean cook stoves, most of the male folk do not like the food cooked in the clean cook stoves because they say the taste changes. So the clean cook stoves are used for heating water for bath, and they use the routine thing. So you need to make big changes in those kind of things. They live in one-room tenements without windows, and intense heating, particularly in Indian cooking, intense heating can increase. So we have a case study of a e-rickshaw driver, a tuk-tuk driver, and his wife, and we gave them a monitor, personal monitor, and a sensing device. And at the end of 24 hours, we found the women had almost 247 micrograms of PM2.5. The man who traveled all over the city had 50. So there, within the family, there's a difference. So we need to look at those kind of dimensions too.
Fascinating case study there, and also some of the other points that you raised really very pertinent. I'm aware actually that we're almost at time. I'm just going to turn to our audience and see if there are any other further questions or comments. We've had a fascinating conversation and really some important data points that has arisen, some interventions that has arisen, some instructions to the cardiovascular as well as the public health community. I'm going to give each of our panelists, starting with Professor Haydon Ken, an opportunity just to sum up in a minute what you would say is the strongest point to empowering a generation for free cities.
Thank you. I think clean air is a kind of human right. So we should, in the future, I think we should encourage the government to take strict measures to control air pollution. For example, here in China, the Chinese government is considering to revise its air quality standard. For example, the current air quality standard in China for PM2.5 is 35 microgram per cubic meter. the central government in China is now considering to revise the standard from 35 to 20. So it's a big step move forward. So we should in the future encourage our government to take even strict measure to control this important health risk.